Thank you. So let me welcome everyone to this virtual via Zoom special meeting on behalf of the National Capital Area Chapter, the Depression and Bipolar Support Alliance. We have a speaker presentation today by Dr. Elizabeth Ballard of the National Institute of Mental Health. She received a PhD from the Catholic University, has extensive experience working with suicidal patients, did a predoctoral internship at the Department of Veterans Affairs, Eastern Colorado Healthcare System, and a postdoctoral fellowship at the Johns Hopkins School of Medicine. And she leads suicide research within the branch, why am I not seeing the name of the branch at the National Institute of Mental Health? Dr. Ballard works at NIMH with Dr. Carlos Zarate, who is our medical advisor and who has helped to arrange this and other recent programs and has spoken himself, and we hope we'll have more such programs. Stephanie, did you want to say, by the way, Stephanie here is an officer with me, and she's put our officer titles, I guess, into the thing. Stephanie, do you want to say more about the specifics of tonight's talk?
No, let's just hand it over to Dr. Ballard.
Okay, if that's good. Dr. Ballard, please go ahead. We'll watch the slides. There'll be an opportunity for questions as we go on. I guess people can use the chat. Thank you.
Great. Let me get all set up. Okay, can people see the correct slides? Just the slide, Science of Suicide. Does that look okay?
Yes.
Yes.
Okay, so thank you so much for the invitation to talk to you today. I'm a clinical psychologist, and as was said before, I work in the intramural program of the National Institute of Mental Health with Dr. Zarate. So I am a federal employee, and so I have to say things like I have no conflicts of interest to disclose, but any opinions expressed are my own, and of course do not represent the opinions of the United States government. So I always like to end with my take-home messages, and for any time I give these sorts of talks, I say, when in doubt, ask. There's just sort of not knowing or speaking in code really doesn't do anybody any favors. And for the most part, especially if you're worried about somebody's suicidal thoughts, when in doubt, sort of ask them directly. I am a true believer that suicide prevention occurs before somebody even becomes suicidal. I think that child abuse prevention is suicide prevention. I think sort of intervention at the school level is suicide prevention. And so that's a real theme of the research, and that treatments can help after someone has suicidal thoughts. And I'll get into some treatment options. And then I hope everybody knows there are resources, but there's always 988 and crisis text line if people are experiencing suicidal thoughts. So for today's seminar, I'm first going to talk about suicide and sort of the overall difficulties, especially with sort of understanding and studying it. I'm going to talk about sort of some recent studies that we've been doing at NIMH. And then I'm going to try to discuss two potential treatments for suicide risk, ketamine, which I know a number of my colleagues have also presented to you on ketamine, so it's going to be a very broad overview, and then safety planning, which is psychotherapeutic. So as a reminder, NIMH is located in Bethesda, Maryland. And so there's a whole half of NIH that gives out grants to universities all over the world. And then we have our own research unit in Bethesda, Maryland. So I'm not a part of the part of NIH that we give out grants. I'm at the part where we have our own inpatient unit where we're able to study participants. And usually by the time people get to us, they've tried a lot of treatments. They've tried a lot of things. Nothing has seemed to work. And so then at that point, they come to us and sort of potentially try something new. So all of this data is from the Center for Disease Control. But in 2023, over 49,000 Americans died by suicide. And it's estimated that that means that's one death every 11 minutes. Even more than that, many adults think about suicide or even attempt suicide. And so some of the statistics are 12.8 million seriously thought about suicide and even 1.5 million attempted suicide. And then for every death by suicide, there's many more people who need additional services. There's many more people who are hospitalized, who go to the emergency department related to suicide, people who self-report having an attempt, and then even more people who seriously consider. So the numbers are very sobering in terms of deaths by suicide, but it's important to remind that there's even more people who are, seriously considered or affected by suicide. And this is from the American Foundation for Suicide Prevention. And then there's, as was mentioned before, suicide loss survivors. So that every time somebody does die by suicide, there's a number of people who experience it. And it affects families, it affects friend groups, but it also affects entire communities, schools, colleges, churches, workplaces, hospitals. It really has a tremendous impact. So this is a bit of a theoretical model of sort of who we study. And so I wouldn't get sort of caught up in all of the details with this, but it's how sort of I think about suicide risk. So this is the idea of a chart. And so on the y-axis, you have sort of suicide risk from low to high. And then there's this imaginary, theoretical threshold for sort of making a suicide attempt. And then time is across the x-axis. And so the idea is there's many people who go along their lives and it just never occurs to them that they would want to take steps to end their lives. Then there's people with psychiatric and mental health diagnoses. And what we know is actually many people with psychiatric diagnoses, mental health diagnoses, do not seriously consider or attempt suicide. It's actually the majority do not. But then there are people that sort of reach the point that they've had an attempt and then maybe they're not having an attempt right now. They're feeling better right now. And then there's people in active crisis. There's somebody that you're really worried about, maybe needs to go to a hospital, maybe needs to talk to a doctor, a therapist. And so I give this because there's lots of trajectories. Like somebody could be in crisis and there could be somebody who was in crisis 20 years ago, but is doing fine now. And I like to remind myself about sort of all the different trajectories when we think about treatment, because there's treatments that happen when somebody is in crisis, when somebody really needs treatment right now. And then, as I was alluding to before, there's interventions that we can be thinking about. What do all kids need? What do all kids need? We know that most psychiatric diagnoses start in adolescence. And so, what could we be doing really early in life for everybody, especially like teaching kids about emotions, sort of like I said, sort of making sure that they're in a safe family environment that, sort of puts them on the right trajectory for the rest of their life. And then sort of what happens after an attempt, after a hospitalization, what do we need to do to help people in that state? And so I give this as just a reinforcement that treatment is going to look different, sort of depending on sort of what's going on with the individual. It's not all one size fits all. There's no magic drug or therapy that's going to just automatically sort of fix all of these problems. We have to think about treatment in a different way because people experience risk in different ways. So we enroll people with histories of suicide attempts into our research. And I try to always meet with them and sort of just talk to them about sort of what happened right before their attempt. And so what they report to me, and so this is unpublished data, is a lot of them report that there was a stressful event just before sort of they maybe had a suicide attempt. A lot of them report sleep problems, and so I'm going to go into some sleep findings. And then that the length of time sort of when they decided to act is very short. And so sometimes it's an hour or less. And so sometimes you worry about sort of people being impulsive. And so it's just this, I say to emphasize, like there's a lot that can be done, but there's a lot sort of you need to do before somebody becomes suicidal, just to make sure, everybody has good social connections, there's a safe environment, and just the importance of sleep. In terms of treatments, there are some, but there could be more. So there's medications, including lithium and clozapine, which have been used and are associated with reductions in suicidal thoughts and behaviors. There's psychotherapies, including what's called cognitive behavioral therapy or dialectical behavioral therapy. I've been trained on both. They are both very powerful treatments. Cognitive behavioral therapy is usually a few weeks. Dialectical behavioral therapy or DBT can, doing it, we ask people to commit to a year of treatment and group therapy and phone coaching. So that can be really powerful for people. And then there's the long-standing history of electroconvulsive therapy, which is often quite controversial, but does still happen in hospitals. The next generation treatments that we study at NIMH include ketamine, which I'm sure you've heard about before, but I'm going to go through again under Dr. Zarate, and then transcranial magnetic stimulation, which is a new form, which is not the same as ECT, but also involves stimulation of the brain, which some people do find helpful. So why, I focus a lot on sort of the time frame of sort of what happens with somebody sort of going into a hospital or, sort of leaving a hospital. And so what we know is sort of there's these what's called critical windows for suicide risk, when you're particularly worried about what something might happen to somebody. And it's the week after sort of they enter a psychiatric hospital, and then a week after they leave the hospital. And then that's also the time when our medications don't work as well. If you've ever been started on or seen somebody be started on an antidepressant, and like more typical antidepressant, it can take weeks or months. And so basically, when you think about somebody potentially leaving a hospital, they need to be connected maybe with a new therapist and a new psychiatrist, and they might not know them as well. And that's overlapping with the time when their medications might not be working as well. And so a lot of what I think is that we need to find treatments that work quickly. That what if, somebody comes in they're in crisis, and we can get them a treatment where they can just get somewhat immediate relief in the short term. And then we can link them to the other treatments, like you're going to, maybe make people feel a little bit better, give them a little bit of respite in the short term, and then connect them to the longer term therapies, the longer term resources that can help them over the long term. So again, a lot of what I think about is sort of what's going to work in the short term, and then what's going to work in the long term for people. So that's overall sort of the issues with suicide research, and sort of what I think is in the background when I do a lot of my research about sort of what are the needs of people. Now I'm going to talk about some findings that sort of we've been going through with our group. So one of the markers I'm always very interested in is sleep. I find sometimes, disclosing suicidal thoughts and behaviors, there's a lot of stigma there. And so people might not want to say something about that. They might not want to engage about that in therapy. However, I think most people, it's very non-stigmatizing to say, I could sleep better. I know I could sleep better. And so sleep difficulties are associated with future risk for suicide attempt. And it's a really important and what we call potential modifiable, because we do have treatments for sleep. And so what if it turns out somebody's suicidal thoughts are being driven by sleep problems? Maybe we should be getting them help with their sleep, and then maybe their suicidal thoughts could get better. And what's interesting to me is the time period of midnight to 5 a.m. is maybe a particularly high risk time for suicide if you adjust for time awake. And how I think about this is, if you think about sort of midnight to 5 a.m., if you're awake, it probably means that your sleep's not very good. Additionally, your therapist and your clinicians aren't usually available during that time. Most clinicians have some sort of out of office message, if this is emergency, go to the emergency department. People might not have access to friends or family during that time. That's usually the time where you're, if people are using drugs or alcohol, that might be wearing off. And also just biologically, we are on a circadian rhythm and our bodies are not meant to be awake in the middle of the night. Like I don't make my best decisions at 3 o'clock in the morning. You're just your mind, you don't make sort of the most logical decisions at that time. So something about being awake in the middle of the night may be particularly high risk for suicide. And that all of that brought into sort of some studies that I'm going to show you. So we are able at NIH to do sleep studies. So people come in and sleep in a special unit hooked up to an EEG, and we're able to track their sleep and wakefulness over the course of the night. And so to explain these charts, we have time of night across the bottom, so you can see that sort of midnight through 5 a.m. And then you have minutes awake across the y-axis. And so it's called spaghetti plots. You can see that there's lots of wakefulness in our depressed patients over the course of the night. And then as an example, we have individuals without any psychiatric history, and you can see there's some wakefulness over the course of the night. Right. This is what happens when you look at sort of what happens in the morning. So that we have sleep quality of individuals with suicidal thoughts. You still see that pattern of wakefulness over the night. You see sort of all of those lines. And then on the other side, you have people who do not have suicidal thoughts. Everybody's depressed, but it's just who has suicidal thoughts and who does not. And basically, overall, time spent awake at 4 a.m. was related to suicidal thoughts the next day, even when we do all the adjusting for depression, diagnosis, and age and gender. And so this was interesting. So what was it about sort of being awake in the night? Is it, some people are awake and they're thinking and ruminating? Is there something biologically going on? So there's a lot to unpack and explore. And then we looked at what happened after ketamine. And so just as a brief reminder, ketamine is a rapid-acting antidepressant, which is also associated with improvements in suicidal thoughts. Not for everybody, but for some people. And so what we did was we looked at what happened to people's sleep after they received one administration of ketamine. So on one side, we have patients with continued suicidal thoughts after ketamine. Those are individuals who had suicidal thoughts, received ketamine, went to sleep that night, woke up the next morning, and still had suicidal thoughts. And as you can see, there's still a lot of wakefulness. On the other side, you have patients without suicidal thoughts after ketamine. So those are individuals who had suicidal thoughts, received ketamine, went to sleep that night, woke up the next morning, and no longer had any suicidal thoughts. And so you can just even, without me reporting all the statistics, you can see this difference, and you really can see that at this point, these individuals who both received ketamine and had a good response to ketamine had improved sleep, and it looks more like individuals without a psychiatric diagnosis. And so to me, we still have to unpack what a lot of this means, but really sort of signals the power of sleep and the power of potentially getting people sort of a better night's sleep and how they feel the next day. So I'm also going to talk about some neuroimaging. So like I said before, talking about suicide can be very stigmatizing. People can be worried about hospitalization. They could be worrying about sort of judgment. And so I'm really interested in developing neuroimaging tasks that are, that we can use to understand the brain of somebody who's seriously considering suicide, but not necessarily always requiring somebody to talk about it. And so I'm going to go through One task, so we're doing different sort of attentional bias tasks. Sort of we're just showing people words. That's called a dot probe task. The life, death, implicit association task is what I'm going to show you on the next few slides. So I'll explain that more. And then we're even just showing people movies of sort of sad things in the scanner to understand what's going on in the brain when they see these sorts of things. So what I'm going to be talking about now is called the life, death, implicit association task. So this is a computerized task that is meant to measure the implicit association of the self with death as compared to the self with life. And so this 5-minute task back in 2011, Matt Knock up at Harvard showed that this 5-minute task would actually predict long-term risk for suicide attempt. And so this is what the task looks like. It's a very simple reaction time task. So you have a screen, and then on one side you have death or me, and on the other side you have life or me. And then you're shown a series of words in the middle, and you're just asked, does this go on the left or the right? So suicide is a death word, so it goes on the left. Alive is a life word, it goes on the right. Myself is a me word, so it goes on the left. And them is a not me word, and it goes on the right. So then what happens is the categories change, and then you see the words again. So again, now suicide is on the right. Alive is on the left. Myself is on the left. And them is on the right. And so why I'm walking you through this, again, simple reaction time task. You're not telling people to interpret it or tell you if you're suicidal, but it's just how fast are you to categorize the words? And what it appears is individuals at highest risk for suicide are faster, faster in the death or me condition than the life or me condition. So again, it's a subtle change. People don't usually even notice that they're sort of have a difference in the reaction time that might be indicative of some sort of association they have between themselves and death that is sort of illuminating some sort of risk down the road. So I was really fascinated by this. Like, so I don't really, like, what does this mean? Like, how can this be used? And so what we did was we brought this into a scanning environment. I work with a lot of brilliant neuroimagers, and we brought both on what's called 3T MRI or MEG, just different ways of looking at the brain. And we saw similar patterns. First, we did this with individuals sort of without suicidal thoughts or behaviors or without mental health diagnoses. And we found similar patterns of activation in an area called the anterior insula, which has something to do with focusing attention. And then we looked at this across what's called our neurobiology of suicide protocol. So across individuals with suicidal thoughts and behaviors. And basically on this same task, we see different patterns of activation in response to this task, sort of especially with the individuals with the most recent suicidal thoughts and behaviors. So they had different patterns of what's called gamma power in the orbital frontal cortex. And what's particularly interesting, so we saw sort of differences, especially in these high-risk individuals, and then we gave them ketamine. So it's a very small sample, only 5 people received ketamine. And then again, they looked more like the sort of initial brains that I showed you before. So we saw these different patterns when they were in the suicidal crisis or a suicidal state, and then they got ketamine. We did the task again, and then now they look more similar to people, again, who do not have this diagnosis. And so again, ketamine short-lived. This is a very small sample. I'm looking into replicating these findings now, but suggests that this is a potential sort of brain marker related to suicide risk that responds to treatment. So for the next part, I'm good on time. I'm going to talk about 2 potential rapid-acting treatments for suicide risk. I'm going to talk about what's called safety planning and ketamine. So safety planning is a brief 1-page list of possible coping strategies to use in the case of a suicide crisis. What it is not a suicide contract. You're not asking somebody to sort of guarantee that they won't take steps to hurt themselves. It's more a way to get on the same page for the individual. How are they feeling? What happens if their suicidal thoughts sort of come back. How I usually explain it is we know that when you're in crisis, sort of your cognition, you find it harder and harder to think, especially think clearly. And so having a way that you've already sort of planned out ahead of time, okay, if I get upset, like this is who I'm going to talk to, this is what I'm going to do, can be really powerful. So it basically has the origins in therapy research. So most any psychotherapy related to suicide, and actually most sort of best practices related to suicide, has some sort of safety planning or crisis response planning. But then Stanley and Brown sort of took just that sort of that safety planning element and said, well, maybe this is just helpful enough that we should really like do this lots of different places. And so it's studied in emergency departments and especially in the military and in veterans hospitals. So this is one trial. So this was veterans in the emergency department. So over 1,000 veterans were randomized to receive some sort of safety planning intervention or sort of what's called typical care. And so just this brief intervention was associated, and again, this is a one-session intervention, was associated with a 45% reduction in suicidal behavior at 6-month follow-up. So really showing that sort of a brief intervention can have long-term implications. So what does it consist of? I'm going to give you some general examples of warning signs, coping strategies, social contacts, emergency contacts, and reduction of access to lethal means. So warning signs are always very specific to the individual. Everybody has sort of different factors that might lead them to be in crisis. And so that can be hopelessness, that can be social withdrawal, that can be sort of being online too much, not talking to friends at all, increased alcohol use, anxiety, difficulty with sleeping, or rumination. And again, what's important when you're working with somebody is just to see, have them think about sort of what are the warning signs for them. And then there's coping strategies. And I try when I work with somebody to make sure that I have sort of different types of coping strategies. There's the distracting coping strategies like movies. What are the funny websites? What's the fun music that's going to make you feel better and not worse? Sometimes in certain therapies, you make a hope box where you sort of put all the sort of pleasurable things in one place. So somebody doesn't have to think of like, oh gosh, where's all the things I like? You can just be like, no, I just have to go to one place with the hope box. Even when you work with kids and adolescents, sometimes there's like apps on their phone that you have. You have sort of the go-to pictures and music, and sort of contacts. You have them go to that app. And that's all in one place, sort of to make sure sort of that they have all of those resources at their fingertips. I think it's always important to have something that's sort of self-soothing and sensory. So like there's things to distract your mind, but then there's also things to sort of calm your body. You said pictures like hot tea or sweets or good smells, maybe taking a shower. And then, of course, there's things like exercise, taking a walk, going outside for a change in temperature, having a cold glass of water, anything you can do to sort of sometimes those temperature changes and just changing your body can sort of help reset your mind. Social and emergency contacts. So there's when I work with somebody, we talk about sort of social contacts. There's the people that don't really need to know all the details of what's going on. There's just the people you call when you want to reminisce or have a laugh or something like that. And then there's the emergency contacts, and that can be parents, other trusted adults, clinicians, national suicide lifelines, and the like. Means restrictions means restricting access to things that could be used to hurt or kill oneself, including knives, pills, firearms, etc. This can be controversial and difficult to confirm. And so, especially people's beliefs about firearms. How I think about it is, like I said before, like at the beginning of this talk, you think about sort of the suicide crisis is often made very quickly. And so what I'm wanting to do is I'm just trying to add minutes or seconds to a potentially impulsive behavior. So as much as we can, if somebody won't give up, certain lethal means, like can we put it in a locked box? Can we give it to somebody else? Can we just we're just trying to slow down. And like in this case, like I said, we're really just trying to add minutes, make it a little bit harder for somebody to access something that could really hurt them. And there's powerful research saying that enlisting family and friends can be helpful in this sort of means restriction. So this is an example. I think I did this as an example of like working with an adolescent. You know, warning signs like for this person, this again, just case example, crying a lot, hopelessness, and drinking too much. Coping strategies would be watching funny videos online or taking a walk. Social context for support, I'm going to call Karen because she makes me laugh. But I'm going to call my parents because they actually know what's going on. Emergency contacts, Dr. Ballard's phone number, and then 988. And then reducing access to lethal means is give razors to her mom. So again, this is, you know, this is a lot of work. This isn't something that can just sort of, you just dash off right away, but is something that can be used as a resource if, you know, in this example, this adolescent starts to feel bad again. Hopefully she can sort of remember, oh, I talked about this with Dr. Ballard. Let's see if any of those things could be helpful. So that was safety planning. So that was very much psychotherapy. Now I'm going to be talking about ketamine, which is quite different. And like I said, I know a number of my colleagues have presented. So I'm giving very broad overview, happy to discuss more. The neurobiology of ketamine is one of the foci of our lab. So ketamine is a widely used dissociative anesthetic. It's been used for decades for pain, surgery and pain. Anesthesiologists are very familiar with ketamine. It's also abused as a club drug. If people have heard of the terms like Special K, K-hole, or something like that, this is a drug of abuse that's used on the streets. And it was first described as having antidepressant effects in the year 2000. And Dr. Zarate, who is the PI of our group, was the first one to describe its antidepressant effects in a randomized clinical trial. So I'm not going to go through all of this. Basically, what to know is that ketamine works in a lot of places in neurobiology, a lot of places in the synapse. And it has a distinct mechanism from other more traditional antidepressants, especially like Prozac and others like SSRIs. It works on glutamate and the NMDA receptor, and then most of our typical antidepressants work on neurotransmitters such as serotonin. Me. So why I came to this particular lab, like I said, I'm a clinical psychologist, trained a lot in psychotherapy, but I was fascinated that ketamine seemed to have these effects on suicidal thoughts because, as I said before, nothing really works right away in terms of suicidal thoughts. And then we have this intervention that potentially did. And so this was a meta-analysis a number of years ago that we did of the effect of a single dose of ketamine on suicidal thoughts. And so basically you do see effects of ketamine on suicidal thoughts within 1 day. The strongest effect is in 1 day, and then it lasts up to about a week. There's always the question when I would give talks about this is sort of what happens, you know, so Dr. Zarate, like I said, did some of the basically the first trials of ketamine in depression, and then some of the first trials for ketamine in suicide. And so like, but what happened to those individuals after they left? What happened to them after they left our studies? And so we did a follow-up assessment of a number of these individuals that and showed that participants who had received ketamine at NIMH were more likely to sort of seek out ketamine post, you know, after they left us, which makes sense, you know, if they liked it, especially, and if it worked for them, I hope that they would be able to find it outside of here. But importantly, we did not find any indication of dependence, that people, you know, sort of were using more than they needed to, or seeking out ketamine in sort of unsafe ways. But that individuals who continued to use ketamine were more depressed than those who did not, which makes sense. I mean, we have to evaluate that more, but it's highly likely that if you aren't feeling depressed, you're not going to seek out interventions such as ketamine. And what's been interesting to watch is that it's really taken off, that there's been this proliferation of ketamine clinics, especially at the beginning. There was a lot of worries. As I said, ketamine is usually, it used before, was usually prescribed by anesthesiologists who aren't mental health providers. And so I think that worry, I think most all reputable clinics will have mental health professionals on site. And I think that's understood that that's sort of the standard now. But it's really sort of this intervention that didn't exist 20 years ago. And so sort of the clinics that we see in the area, it's really new and different. And so there's a real variety of experiences, administrations, and expertise. So I'm not going to go through this in detail, but just so people know, there's things like esketamine or what's called Spravato. So that's a slightly different formulation of ketamine. It's an intranasal version, and it was sponsored by pharma, specifically Janssen. The effect is generally the same on depression, but I will say it does appear that there might be a slightly reduced effect on suicidal thoughts, just from the literature that I've seen. So it's a little more mixed that way, but it appears to be safe for individuals with depression. And then something I do not study at all is psilocybin and other psychedelics. And so that's another burgeoning area. And the treatment experience is more likely to be you're more likely to have a therapist or a guide with you. So the ketamine that we study is 40 minutes, and it's very, especially at NIH, it's very medicalized. You're in like a inpatient unit, you're in a medical bed, you have two nurses and a nurse practitioner or a MD watching you, monitoring you, but we're not doing psychotherapy during it. And you're a little more likely, if you're doing psychedelics, that's over potentially like 6 to 8 hours. You might have one or two people with you, just making sure, they can provide support and guidance. It's more of a trip that way. I already talked about ketamine, esketamine. It was approved, and as I mentioned before, we didn't see great distinction between esketamine and placebo for the scores. So the concerns for the future is, at-home ketamine use. Again, this is not what I do, but, it's just been interesting to see because the field is constantly changing. So this was a report done a couple of years ago about, at-home ketamine use, and Americans who tried this reported either accidentally or purposefully using more than their recommended dose, and 21% reported using ketamine or other psychedelic drugs to self-treat anxiety, depression, or other mental illnesses. And this has been it's really been an interesting time for the field because in general, what we were taught when I was in my graduate program is that basically you're going to develop an intervention, and then it's going to take like 15 years to get other people to do it because it just takes such a long time to develop the research and then sort of have people have access to your treatment. And instead, the ketamine, story, people have been so excited and so inclined to use it that, things just keep changing all the time. Like the at-home ketamine use was not something that, we were talking about 5 years ago. And so now it is, especially after COVID. So the research that we do, I showed you some findings from the neurobiology of suicide protocol. Basically, the groups that I presented before, we recruit, and then the individuals at the highest risk do have the potential to get ketamine. We do lots of, imaging, sleep, collect blood to look at markers there, ask about psychiatric symptoms and clinical symptoms as well. And then have a specific study. American Foundation for Suicide Prevention gave me a grant. And so basically that IAT, that implicit association task with the words, we're doing pre and post ketamine, before and after ketamine. And then we're also showing people movies. And so it's a lot of understanding what's the impact on mood, what's the impact on sort of these tasks, on sleep, on brain. We have smartphone sort of questions, querying people about how their mood is. We're tracking their activity, and then sometimes we have them talk into a video recorder to look at their speech and their facial expressions. So I'm back to the beginning again. So this was a whirlwind tour. I talked about suicide. I talked about a bit of our research, and I talked about safety planning and ketamine. But in the end, these are the things that I hope I will leave with you. When in doubt, ask. I know it's not fun to hear about oftentimes suicide. This is my job. I love talking about it. But I know it can be tough to hear about, especially if you have like a suicide loss survivor or sort of have people who are struggling with this. So I appreciate you all sticking in with me here, but I really think it is powerful to ask. Suicide prevention can occur before somebody becomes suicidal, and I think there's a lot of things we could do to strengthen mental health within our communities that really ends up being suicide prevention. And then there are treatments that can help after somebody does experience suicidal thoughts. And then I gave this before, but I'm giving this again. There are resources available online and text. And so this is a tremendous amount of people that do this, including my principal investigator, Dr. Zarate, and your medical advisor. So that was it for me. I think I'm going to stop sharing now and see what questions I can answer.
Yes.
Oh, we have questions. Okay. Can ketamine be used in teenagers? So yes, it can. It's done very sparingly. The studies are still, there's been some promising studies, but I will say they're even harder to do than the studies for adults, just because there's the concerns about, the parents might have the concerns, there's concerns about adolescent brain development. So it's much harder to get ketamine for a teenager than you could get for an adult, but there is research going on. Most of it is at places like Yale and some great places in Texas. I don't know if there's clinics here that would give ketamine to a teenager. Can ketamine used by individuals bipolar? Yes. So some clinics won't. I mean, it's basically according to what the doctor decides. But Dr. Zarate was basically the first person to also show that you can give ketamine to somebody with bipolar disorder. I think there's always the concern with somebody with bipolar disorder that you might sort of lead to a mania. There's not really evidence for that, but people have to be very careful. What we tend to do is make sure that people are maintained on other medications to help with mood stabilization before they get ketamine. So that's why having a mental health professional and not just an anesthesiologist do this is really important. Do psychedelics prove better results? I think that's open for debate. The psychedelics, as of now, are not FDA approved for treatment. But I think that, there are people who respond to one or not the other. I think also because of the psychotherapy, I think there are people who will have a psychedelic experience and then, if they have good therapy, it can be a little life-changing, a lot of new perspectives. And so I wouldn't be surprised if some people would find psychedelics more helpful. But some people don't want that and they want the ketamine and continue to receive the ketamine. So I don't think that I've seen a head-to-head comparison of the two, but my educated guess is it's going to be different. People are going to respond differently to the treatments. I think Wendy has her hand up.
Yes, thank you so much. I just want to give you so much praise and thanks for bringing this research to us. And as I mentioned just briefly at the intro, so I'm a survivor of suicide loss. I'm third generation bipolar, lost my grandmother, my father, and then my best friend at UCSD, who was just post his dissertation at Stanford. A lot of literally 8 other white men that I've lost. So the research that you brought is so impactful and powerful, and your delivery to make it sound so common sense and just to illustrate these very sophisticated ideas in such a cogent way. I'm so grateful to you and for what you're doing for the field and for humanity, really. But I had so many points of curiosity, but one really was the very simplistic nature of the study where you have the words that you put from column 1 to column 2. I'm so fascinated by how such a simplistic design of a study could yield such very profound results. And I'm just wondering, like, who designed the study and how did they even come up with such a device to learn so much more about the neurological aspects of the brain?
Yeah. Well, yeah, and I did not design it, so I will not take credit. But yes, it is fascinating. Social psychology does a lot of these reaction time tasks. And so there's been, like you can do that task about like women in science versus women in humanities or something like that. And there's stuff related to race. So that's why when I say it's a little controversial, especially now in the current environment, it is a little controversial. But the underlying is that sometimes we have these sort of split-second reactions to different words. And so I think that's what it's capturing. But understanding really like what does that mean? Like as you're sort of alluding, it's just a simple task, but that's not the same thing as sort of actually taking steps to end your life. And so that's why I want to explore more. And I'm really fascinated by what I mentioned before, sort of like showing people movies or showing people that's a little more realistic and a little bit more real world to understand it more. But I really appreciate what you said. And I appreciate all of what sort of you all being here on a Thursday night.
Yeah,
And
I have two little
yeah.
follow-upper ones.
Mhm.
One's ultra nerdy and one's not nerdy, but
Okay.
my non-nerdy, thing, I was so delighted to see how what I consider very common sense interventions in young people or people, period, in terms of like, oh, let's just provide a few coping strategies, or oh, let's get our little lavender candle out, or these kind of very concrete ways that there really are game changers for people, and it's just reassuring for me to hear that, yes, in fact, if you just do like if you're just a friend and you come into that space, you're not doing, question, persuade, refer. You're not like doing quote unquote, like, you're not doing that kind of intervention. You're saying like, oh, can I get you a donut right now? I mean, that to me is so amazing. And to see it like really proliferating in the research is just, I'm so excited about that. And then the other one that I was wondering about, though, is the ketamine, the actual mechanism that ketamine, like how that mechanism even works. Because, of course, we're also saturated with like, oh, you've got the serotonin one, you got the dopamine one, you've got the Abilify one, blah, blah, blah. But like those, yeah, they're not working like on a split second basis, right?
Right.
They're not the game changer that people really need in that impulsivity stuff. So, yeah, I mean, as we know, like someone, if they have the firearm at the ready and then boom, it's game over. So, I mean, I was loving to hear that the ketamine has such an immediate impact, but I really don't understand it at all. So, I was wondering if you could give like a very layperson description of why it's so different than these other like traditional pill form ones that are so popular.
Yeah, I'm going to give, and so that is that's the focus of our whole lab, and it's what's called a dirty drug in the sense that it works in lots of different areas. So here is I'll try to make this sort of lay person. So there's neurons, right? Sort of there's the brain cells. And so can you see my pointer? Can you see
Yes,
it? Okay.
thank you.
So this is sort of one cell, and there's the synapse and then the next cell. So this again, simplistic, most of the serotonin, like most of sort of the more traditional antidepressants, like selective serotonin reuptake inhibitors, they work at the presynaptic, at sort of this cell and sort of releasing things into the synapse that eventually communicates with the next cell. what ketamine does, it basically opens the channels on this cell. So that's sort of what these are, like the NMDAR, AMPA, like these are sort of openings, sort of receptors, but it's just sort of openings. So this is again, very broad view of that a lot of our other treatments work on this level and then sort of each have sort of downstream more subtle changes and it takes a while. And I think what happens with ketamine is it sort of opens a bunch of things all at once. Does that
Okay,
make
so
sense?
in my mind, like it's like Reaganomics, like trickle down versus like grassroots, like we'll just give some people some food,
Yes.
and they're in their card, their WIC card. So yeah, that's very interesting. Yeah, that would be an analogy I would use. But thank you so much, Doctor. You've been really, really enlightening for me and for our community. Thank you.
I agree.
Elizabeth, I like your name. Oh, you're on mute though.
Thank you. Only after 5 years of doing this, or more. So I also want to say thank you so much for being here. And I think this was an excellent presentation. I just have a question that I think maybe it was implied, or maybe you said it and I missed it. But in talking about hospitalization and those 7 days before and 7 days after, with an attempt, is the thought, I mean, it makes sense that you would try to get somebody quickly get some kind of medication treatment and then go ahead and then later, do the long-term treatment. And so are you thinking, this is the part I was implied, that ketamine would be something really good to an option for people while they're in the hospital, for when they get out, then they have a little bit of grace period, that then they can work on finding their doctor or whatever.
Yes, so my background, like I said, I'm a psychologist. I've done the therapy. I've done sort of healthcare systems, like working in an emergency department. And so I try to keep that in mind for my research. And so that's why things like ketamine, but also things like transcranial magnetic stimulation and brief psychotherapy are so interesting to me. I mean, it's great to have a 12-month program if that really works, but like I try to focus on like what's going to make somebody feel better right away. And so there's lots of things you can do. And I think oftentimes our hospitals don't do enough treatment. And so, you have to think like, what are they going to be able to do in a few days? And so I think ketamine is one option. Like I can't, like I'm the government, like we're not allowed to like be like, you have to all get ketamine.
Right.
There's important things you can do, and you also like follow up with people, make sure that they get the therapists that they need, like do the safety planning. But yeah, thinking through like what if you could do ketamine plus psychotherapy is sort of a dream I have. Like, what if you could do both of those while somebody's hospitalized? Would you even get a better effect? And sort of, I think of them, you're just sort of like, there's just this lag and gap while people get connected to their clinicians. And so, like, what can you do in that time?
Yeah, and I also like the discharge planning is so important, and a lot of the hospitals don't have a great they don't do well in that area. And that's when it's so necessary, right? But I was thinking one other thing. Do most hospitals have offer ketamine, or is that?
I don't think so, but I don't
Okay.
I don't know.
Okay.
I get the sense that there are some places that'll have the ECT, some places that'll have the ketamine, some
Okay.
places will not
Okay.
have anything. That's a good question. I feel like I see mostly ketamine being done in clinics and then at sort of large hospitals,
Yeah.
but it's a good question. Like but I haven't looked at it recently. And like I said, so psychiatry changes so little, and to have these huge changes over the last 10 years is really new and different.
Yeah. Okay. Well, thank you so much. That's
Oh,
helpful.
you're welcome.
Let me ask, is it generally either or between offering ketamine and offering ECT?
I don't necessarily think so, but I don't, I guess was talking to somebody at I'm in the DC area, like Sibley versus Suburban, and they were explaining, I don't remember which one was which, where they're just like, we do ketamine here and then TMS there, you know, or something like that. So I don't, and that's all within the Hopkins system. This is just a
They're
case
both
example.
Hopkins.
I do not work at those places, you know. I might be wrong, but I think it's a lot to do these sort of relatively new treatments.
Yeah.
And so I think it's hard for a local hospital to have all of those things done well.
Well, ECT isn't easy, but it's not
Yeah.
new.
Right. It's not new.
Let me note that there's in the chat a message of thanks for an excellent presentation
Thank you.
from Judith. Are there other questions, thoughts, items anyone wants to say? Oh, here's please check the chat for the message from Wendy. DBSA California is hosting program on big farm on the FDA maps and big pharma. Ask the expert talk on third Thursday of the month. So check that out. We'll try to include that in our weekly email chapter newsletter. And I mentioned our website, dbsanca.org. If you go there, you can click on the newsletter, view the most recent newsletter, and click to sign up to receive it each week. I should also say this program Stephanie asked for forward that to her. This program has been recorded, and it will, when we have, can process the recording, have the slides, we will make this program available on our website, dbsanca.org, as we have previous recent virtual speaker programs. So people will be able to go to it if they missed the program or if they want to see it again and watch it. Wendy, did you have a hand up?
Yeah, one last thing. So the YouTube video of this project, this presentation here, DBSA California on our website, we have a YouTube channel. We have like 10 or 12 or blah, 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 a lot of YouTube videos. And I would love to shamelessly steal Elizabeth's talk to put it on our channel for as much visibility as it can get. So I know a lot of you know me as a stranger or a newbie, but if you would I would love to partner with you at the National Capital area to get more visibility for this talk, which was just so amazing. So
I want to say I think that's fine with us as a DBSA chapter. We can talk about doing more of that. It's also I take it, I presume, but it's up to Dr. Ballard also to indicate that this is okay.
I think so, but I can check. I think I
Okay,
don't, if it's
please
within
do.
the DBSA, I don't know why it wouldn't be fine, as long as it's fine with you, Alvin.
Yeah, we'd like to learn better how to share all this information and plans for programs among different chapters. We've had a fairly nice turnout, but I hope we can attract more. Are there other things people want to say, ask about? Anyone? Stephanie, did you want to say anything?
No, just to thank Dr. Ballard for a lovely talk.
Yes, and I, of course, second
It's
that.
fun.
We're all appreciative. And we will send out an acknowledgement, but if unless anyone wants to say anything else, including Dr. Ballard, otherwise we're very happy to have done this program, and it'll be available, and look forward to our announcement of future programs. And I guess we'll end the recording.
That's great. Thank you all, and thanks for the great questions.
Okay, thank you, Dr. Ballard.
Thank you.